Healthcare maintenance. Now, latest ADA guidelines. This is the part of the lecture where I transition a little bit into our preventative services approach towards diabetes, okay? Latest ADA guidelines can always be found online. Our Go Diabetes is in the process of constructing a website that has links to all these, as well as every year they come up with changes to the algorithm, so you have your annual updates, so to speak. So they're all available online, but briefly includes lab surveillance, your classic A1C every 3 to 4 months, you know, your urine microalbumins and such, kidney and liver function, diabetic education. This is a tricky one as far as how often you refer people. Technically, you're looking at once a year. Sometimes that's a little bit overkill, to be honest. But most of the time, physicians only utilize this at the very beginnings of things, as in when they're first diagnosed and whenever you convert over to insulin administration. Statistically, that's when physicians most routinely refer people for diabetic education. But the reality is you're missing out on the nutrition components, you're missing out on the constant check-ins and weigh-ins and surveillance. So, and I don't want to step on Amparo's toes for what she does in her next lecture, but I just want to use that as a segue to realize that it's an underutilized resource. Vaccinations, flu shots and such, routine health care. Smoking cessation is huge too. There's a tendency to forget about that one, but realize that if someone's a smoker, they just quadrupled their chances of having heart attacks. Diabetes is a cardiovascular disease process. And if you take smoking and other things and quadruple the risk of that, they're toast, all right? There's no other way around it. You have to focus on that. And for checklists and things, don't just circle, yes, they smoke and leave it. Every time they're there, hammered on that, okay? They have to understand and appreciate what the diabetes is doing to their vascular supplies and what the smoking is then amplifying. Foot exams and eye exams are something I'm going to go into to wrap up my lecture just a little bit, since that's something that's commonly overlooked. Reasons to look at feet. Here's a series of numbers. 70% of diabetics eventually get a neuropathy, okay? The neuropathy frequently leads to sensory loss in their feet. Then 15% develop foot ulcers. So pretty sizable numbers here. Now, more than half of those foot ulcers become infected at some point. So you can start following the math if you want, because it just keeps going. 10% of those infected ulcers then lead to amputation. More than 50% of non-traumatic lower limb amputations are due to diabetic foot ulcers. They are the leading cause of non-traumatic amputations. One amputation increases likelihood of having another one, either on the same limb. Some people have, these FEMPOP bypasses and such, and ultimately just have ascending amputations. Other people, it's just they lose both feet. I mean, you've seen it, I'm sure. And the problem is the 5-year mortality, not morbidity, but mortality rate approach 80%. If you have somebody who has something amputated, the chances of them being around in your clientele for 5 years from now are very low. And you should really think about that when you're doing ultrasounds or ankle brachial indices on these patients and following on their peripheral vascular disease. If they get to the point where they get something amputated, very high mortality rates. So this is why we have to check for pulses, looking at their feet. When we get to this, examine the feet at every visit, an annual comprehensive evaluation, doing the sensation test with the monofilament, which I'll get to in the next slide, the pulses and whether or not they're palpable. If they're not palpable, you almost certainly need to do an ankle brachial index on them. Skin condition, for instance, if they're not having a lot of hair on their legs, that's one of the common tips clinically that we use for having very poor circulation to a limb. You tend to lose some of the hair, or the nails tend to get a lot thicker, or flat out ulcers, obviously. Anatomic deformity, Charcot feet, any other conditions as far as the structural anatomy of the foot. Then the shoe evaluation. What they come into your office on is a frequent indicator of what they actually wear on a routine basis. So everyone little flip-flops or nothing, that'd be kind of weird, but you need to take note of what they're actually wearing when they're showing up at your clinic. Plus, you can often see where one side of it's very worn, or if there's other structural deformities to their shoes themselves. People who are diabetic have to have adequate padding in their shoes and adequate redistribution of weight to avoid those calluses and bone spurs and foot loss. So the sensory exam, 10-gram monofilament. Patient obviously should not watch, but it's worth mentioning. 3 sites per foot. That keeps changing on us. That's one of the other things that we've had to change on the slides, because it used to be 10, then it was 5, now it's 3. You apply the filament perpendicular to the skin, slight buckle of it all in one quick motion, 1 to 2 seconds per site. So looking at a 10-second total test to go over both of their feet. Obviously don't apply it to ulcers or calluses. Most people can't fill a 10 monogram filament on a callus, much less anything else. So the sites, we used to have these slides with the 5 circles, but now the stars have taken over the places where it's easy enough to screen. If they have calluses, you can move to one of those other 2 sites or around to the top of the foot. That you can certainly do that as well. Procedures and billing. Sometimes, as much as we all like to think that we're just altruistic human beings that are out to have good patients and take care of patients, the reality is that this is a business too. And sometimes it takes a financial incentive to get people motivated to keep track of certain routine things like this, like the foot exams. And I'll get to some procedure codes on the next slides. But the point is the foot exams themselves are reimbursable. The protective footwear is something that can be set up that's paid for, not so much for you, but for the patients, that Medicare covers the protective footwear. Nail trimming is a very common procedure that you can bill for, and then debridement of the corns and calluses. If that's not your thing, not what you want to do, fine, send them to a podiatrist or other diabetic clinicians.